So thank you for inviting, thank you for accepting our abstract. So you can see, look at that cast of thousands. And you can see this nice picture. I don't know, who's been to the Charles Perkins Centre? Yeah, see, so what we've got here is the building up there, one of our patients, and this amazing chair. I should have put a normal person in it, but it's a really lovely big chair that's quite, the colour's nicer in real life. It's a beige, not a mustard yellow. And you can see the nice waiting room. So it's a beautiful place, and we're very lucky to have this. And I must say the patients really appreciate it. And this is a very happy patient there, sitting in the middle, who always loves seeing me, even though his weight goes up and down like a yo-yo. Anyway, so what the topic is, which is bariatric surgery safe and effective for patients with super obesity? Put up your hands. Yes? No? Oh, goodness. Let's see. So I think we didn't quite see this slide, but one of the people today showed how obesity is increasing, and not only is it increasing, in general, but it is at the extreme ends of the distribution that is becoming a particular problem. And we've got data from not only from Australia but from the US and the UK that shows an increase in the sort of right skew of the BMI distribution. And this is bad for lots of reasons, some of which I've listed here. So the increase in the prevalence of severe obesity disproportionately increases the morbidity and the healthcare costs. Yes, we had a lovely talk about metabolically healthy obese or the insulin sensitive, but of course that's one problem that is associated with obesity. There's countless others ranging from, unemployment through to bad sex life through to etc. It's not being able to put on your underpants and osteoarthritis, blah, blah, blah. So it goes on. So it's not that there isn't just the issue of metabolic problems, which is why I don't like that term that the surgeons like to use. And of course this group that are getting bigger and at the more extreme ends are on the whole poorer, and they don't have access to the type of excellent treatments that we have, and also they're often very sick, so that also precludes surgery. Now, what are some of the challenges in managing patients with super obesity? And this I've just a bit of a quick literature review that my PhD student helped me get the articles for. Some of these things are obvious, but I hadn't actually thought about it till reading the articles. There are the surgical technical difficulties, the thicker layers of the abdominal wall and the intra-abdominal fat, which means a larger distance between the xiphoid and the esophagus, so it's much harder to get down there. Massive hepatomegaly, increased major surgical complications have been reported, particularly with the possible, gold standard procedures, the Roux-en-Y and the biliopancreatic diversion. Longer lengths of hospitalisation, increased readmission rates, increased costs. There are increased comorbidities with increased weight, increased complication rates and mortality rates after surgery, and possibly less favourable weight loss. However, more recent studies are a little more positive, and but they are generally, and there are studies showing that the less technically challenging procedure of the sleeve is effective in these patients, but studies are generally small. Most of the studies I saw less than up to 20 patients, and in a lot of these studies there's loss to follow-up of, in one study at 3 years only 50% of the patients were seen. However, a couple of promising studies that I've listed are a study with 74 patients where there was a mean follow-up of 73 months, so quite long, and patients were unwell with a mean number of 9 comorbidities. Their long-term complication rates 15%, good weight loss, so their mean BMI went from 66 to 46, and there was a substantial improvement in type 2 diabetes. In another large study, 322 subjects, their mean BMI was 55, and you can see a mixture of operations. And at 3 years follow-up, they had, now what was I trying to say here? I've forgotten. There was similar weight loss with the band and the Roux-en-Y, substantially more with the biliopancreatic diversion, and with that operation more perioperative morbidity, but certainly looking more positive. Let's go down. So what did we do in our study? Our study, we are very fortunate that we are able to do surgery in a public hospital, and we've been doing it since 2009, and we've been looking closely at these patients because we feel that we want to do the right thing, of course, but we also want to determine whether we're doing a good thing or not in order to get more funding if we are actually doing a good thing. So this data I'm going to present, it's a longitudinal follow-up study of patients who underwent bariatric surgery at the Sydney Local Health District over a period of 6 from when it started in 2009, and we classified the patients as having obesity, so BMI less than 50, or super obesity, BMI above 50. And the aim was to determine if there were any differences in the percent weight loss or complication rate in those with a BMI below or above 50. I'm hearing voices. And I'll just get my gun out. And to determine whether preoperative, and then the second aim was another issue that we toy with, which is whether preoperative weight loss might predict postoperative weight loss. We were able to look at this because unlike in private practice in general, a lot of our patients had been seeing us for many years when we first introduced bariatric surgery, so we could see how much weight they'd actually lost prior to surgery, but also to try to have the most motivated patients. All patients have to be seeing us for at least 12 months before they have surgery, so we've got at least 12-month pre-op data on all our patients. And then finally, we also wanted to look whether follow-up was important. I hear that follow-up is not important for rats. I actually asked Randy specifically, because I haven't read all the literature, and they do fine even without follow-up. So Michelle Tan, my PhD student who I mentioned earlier, will be telling you that on Friday morning, so go and listen to her. And so here we go with the data. So sorry about this slide that's got a lot of stuff on it, but I'll just highlight the important bits, which is really that there was no significant difference between the two groups when it comes to sex, ethnicity. Interesting that we have got 7% roughly were Indigenous, which is of course much higher than the background population, so it's good we're getting people that need the surgery and that otherwise would not be able to have it. What do we have here? You can see that if we look, I don't like these pointers, the second bottom column, that 85 of our patients had a BMI below 50 and 48 had a BMI above 50. We mainly are doing the sleeve. The 9 bands were done early. I don't think we've done a band since 2010 or 11. We are now starting to do mini gastric bypass and Roux-en-Y. That's a more recent. These are more recent procedures that are being done. When we look at comorbidities, now that we haven't gone through every single comorbidity, this is just a limited list, but I've calculated 60% of the patients had 4 or more comorbidities, and similar comorbidities in each group, and similar numbers in the BMI less than or greater than 50. When we look at complications, we're actually doing pretty well. I'm not going to have time to go through all this, but the numbers are very small. So perioperative in our total group of 130 odd, just 6, and late complications a total of 10. So better than the reported literature. So, and these patients arguably are a challenging group because most of them are pretty sick and pretty big. And I should have mentioned the mean BMI of our group. Where is it? Oops, because I've forgotten it. So the mean BMI, do I have it here? Mean. First of all, I just should have said the mean initial BMI of our group was 53.1. That's before the 12 months before surgery, and then by the time they had surgery, the mean BMI was 48.6. In the super obese group that I'm going to present, the mean BMI initially was 65.2 and 58.9 when they had surgery. So let's look at the data. So now this shows individual data points for all the patients, and then we've worked out their trajectory. We've got a fantastic biostatistician, and I've gotten here exactly what the statistics were if anyone asks me, because not very good at statistics, that's why we've got someone who's good at it to do it. But I can tell you that their weight loss, this is their percent weight loss from pre-surgery, not the 12 months before, out till 4 or 5 years, was exactly the same in both groups, so it didn't make any difference. And this is the same data, and what this has in addition is it's got the numbers of patients down the bottom, which obviously get less as time goes on, because in 2009 we did 3 patients, because we started at the end of the year. 2010 we did 20, and then the numbers go up and up. So the numbers are getting fairly small at the end. Now, this is the last bit of data that we looked at very quickly, but is quite interesting, which is to look at whether the percent of the amount of weight loss before the surgery could predict the amount of weight loss after the surgery. And here we have on the right the BMI less than 50 group, and on the left the BMI greater than 50 group, and this is just at 6 months, and there's no effect, doesn't seem to be important. But when we go out to 48 months, small numbers, and it'll be really interesting to see once the numbers are bigger, and it's not significant yet, but the BMI less than 50 seem to be behaving differently to the BMI greater than 50, and it seems, unlike rats, that in humans, if you have a BMI greater than 50 and you lose more weight before surgery, you do better after surgery, which is kind of what you'd expect, but it's quite nice to show it, because Sam was worried that she wouldn't have a job. She's just moved to us, and that we just get rid of her and get a surgeon instead, but maybe we'll keep her. At least she can tell us who it's going to work on, maybe. So, to conclude, bariatric surgery is safe and effective in people with obesity associated with multiple comorbid conditions, I think. Bariatric surgery is also safe and results in similar weight loss in patients with super obesity. Preoperative weight loss appears to predict post-operative weight loss in those with super obesity, but not with lesser degrees of obesity perhaps. But the numbers of patients are small, particularly at over 2 years, so the assessment of our longer term data is obviously going to be very important. And also we need to remember that the patients who are having surgery are quite unique in that attendance in our weight management program for at least 12 months is a prerequisite for bariatric surgery, so we do have a very motivated group. Thank you.
Complications of
Yes.
surgery in the 2 groups, did they look the same?
Yes. There was no difference. And it's because there were lots of complications in the laparoscopic adjustable bands. Anyway.
But the bands?
Yeah, I'll go back. I mean, there are very few complications. I was surprised when we went through it how little. So you can see here, if we look at perioperative, there was a hemorrhage in one, there was wound dehiscence and hematoma in someone who was on warfarin, bile leak in just one sleeve patient. I thought there'd be more than that. Pneumonia in one, tachycardia, tachypnea in one. It's really, so 6 patients had, and it was similar. And the BMI group is there listed, and you can see it didn't matter. The bigger ones didn't have more problems.
Okay, yeah, because I think that's an important
Yeah.
little takeaway from this, because I think the general notion is that the surgical the results might be the same, but the surgical complications are so much higher as the BMI.
Yeah, which is not what we saw. But we've got great surgeons, good hospital. I mean, I think it's probably being done as good as it can be.
So, based on what you just said, is your recommendation that the super severe obese patient be funneled into specialized centers, or do you think that they can be seen anywhere?
That's a good question. Look, I think they need to be seen by people who understand all the medical problems related to obesity, who've had their sleep apnea dealt with, who've lost enough weight so that their fatty liver isn't in the way. So yeah, I don't think they should be done out by anybody. I think it is. I think it works well when we do it, put it that way.
Fair enough. Thanks.
Sorry, hi, by the way.
Oh, hi, how are you? He's one of the super surgeons we have.
Interesting, most of those patients with complications were in the BMI less than 50 group, weren't they? There's only 3 patients there with a BMI greater than 50. And
So that means it's good to have a BMI greater than 50 and have surgery.
Yeah, they had less morbidity. Did you have a table at all with the two on it, with the morbidity for the 2 groups?
Look, the
This
number.
is the combined table, isn't it?
But they're all single. I've pretty much got single. They're all. Oh, wait, on number of comorbid. What have I done? Number. Oh no, they're. This. Sorry, shouldn't do it like that. Where's the mouse? This is one person. Each one is one person. That's it. There were very few complications.
But in the terms of the 2 different groups, the BMI under 50 versus the BMI.
Oh well, you can look at it. So there's 1, 2, 3. 3 out of 48 had a BMI greater than 50, and 8 or whatever the rest is out of 85 had a BMI less than 50.
So
The BMI greater than 50 were not at increased risk of complications.
So they had equal weight loss success to the BMI without an increase in complications.
Correct.
In fact, there was a trend toward a decrease in complications.
Maybe we were more careful.
Can I push you even further
Yeah.
with that?
I love to get pushed.
With regards to the weight loss prior to surgery, obviously your patients are on this program 12 months before, but in the below 50, you didn't have any association between the 3.
Well, with those small numbers, no.
Sure. If that's in fact replicated, then that could mean that we don't need to push patients.
Yeah, look, I think that's controversial, but what I did say is that all our patients are very motivated. So even the ones that, didn't lose as much, they've actually hung around for 12 months. So I think they're different to somebody who just walks in and sees, Dr. Smith, bariatric surgeon. So
because we have patients who have hard time losing weight and they still would benefit from the surgery.
I think if they keep on seeing you and they're motivated enough to actually turn up, they probably would do well. But others might say that they'd do well anyway, and we don't know.
And is there a difference in trend between the preoperative weight loss predicting long-term post-operative success between the 2 groups, the BMI and the 50 and the BMI? Have you got any comment on why you think there might be a difference there, why the higher BMI patients are trending toward better weight loss if they've lost weight preoperatively? Or you think that trend is not significant?
No, but I think it might in time. I don't know. It could be a type 2 error. I don't know. It's interesting. It'll be interesting to see. Does it mean that that they've got to work harder? That if the science would say it shouldn't make any difference. The psychologist in me would say that they have to work harder because they've got more pushing them to get obese. So maybe if they've worked harder before and made some of those behavioural or things have happened in their brain, they're going to do better afterwards. I don't know. It's conjecture. I don't know.
All right. Thanks, Tania.
Thank you.